Hello, everyone. Today we are going to talk about and cover aseptic techniques, a part of patient care. So we've got a lot of objectives. First of all, we're going to describe the use of a sterile drape to establish a sterile field. We're going to list the steps in a surgical scrub. We'll describe the procedures for gowning and for gloving, and list the basic principles of sterile technique. We'll describe the procedure for changing a dressing, classify proper techniques for the safe removal of potential hazardous waste material, and describe proper care for a patient with a tracheostomy. We'll also describe the proper care for a patient with chest tubes, describe the care of a patient with a urinary catheter, describe the care for patients that have intra-arterial lines or any contrast intravenous injections, describe the use of fluoroscopy for guidance in the insertion of pacemakers, and identify common sterile techniques that are used during surgery using the C-arm. So aseptic techniques can be applied in any clinical setting. They're used with procedures that bypass the body's natural defenses. Typical situations that call for aseptic measures, they include surgery, the insertion of intravenous lines, urinary catheters and drains. And the goals of aseptic technique, they are to protect the patient from infection and to prevent the spread of pathogens and other harmful microorganisms, to obviously keep things clean. And then we have two different levels of reducing microorganisms. So sanitization or sanitize, reduce the number of microorganisms to safe levels, and to disinfect, remove most microorganisms, but not the highly resistant ones. In that case, that requires sterilization. So we have two forms of asepsis. We've got surgical asepsis and medical asepsis. With surgical asepsis, it's the protection against infection before, during, and after surgery by using sterile technique. Medical asepsis is the removal or destruction of infected material. It's used to assist in reducing the spread of infection. So there's a lot of different sources of infection: skin, hair, the nasopharynx, fomites, air, human error, and cross-contamination. The sterile field is a microorganism-free area that can receive sterile supplies. It's established using a sterile drape. It contains no viable microorganisms, clean and dry materials only, and make sure that everything you're using is unexpired, not expired, and unopened materials. There is a term that you should know, especially for the registry. They often ask about it in the patient care section. What is the sterile corridor? And that sterile corridor is in surgery, that area between the patient's drape and the instrument table. Really, the only ones in surgery that should be in the sterile corridor are the surgeon and the surgical tech or scrub nurse. Let's talk about how do you open a sterile pack. So you would hold the package in one hand with the top flap opening away from the person opening the package. So your first flap is away from you. Then you would pull the top flap well back and hold it away from both the contents of the package and the sterile field. And then once it's all open, you would drop the contents gently onto the sterile field from approximately 6 inches above the field and at a slight angle. So if we look at the pictures, you can see in the top in A, you're going to go away first, then in B, one side, C, the other side, and then D, the side towards you. So the last flap is open toward you. This way you're not reaching over the sterile field. A sterile field is established using a sterile drape, so the drape itself must be sterile. A first step in using a sterile drape is confirming that the package is sterile. We always want to make sure that anything that we are using is sterile. And there will be expiration dates on things. There will be certain tape that may have markings on it to indicate that what we are using has been sterilized. If something appears to have been previously opened or the expiration date's passed, it is considered unsterile. That's even if it's 1 day past the expiration date, we don't use the equipment. So establishing a sterile field. So A, you can see she's holding the drape with one hand by the corner, and B, she's folding back the top to lift the cover and lay the drape then on a clean, dry surface with the bottom farthest from the person that is establishing the field. Once the field is opened, okay, you can see the person here is putting things onto the sterile tray or table. So you want to drop the contents gently onto the sterile field from about 6 inches above the field and at a slight angle. Now, once again, notice where she's dropping it. She's not going to the middle of the sterile field. It's from the edge, the very edge. And it says this technique then helps to ensure that the package wrapping does not touch the sterile field at any time. Sometimes you'll need to pour sterile fluids into a sterile basin, like for example saline, or they may use heparinized saline if they're flushing out catheters. So there's a proper way to do this. So we want to hold the bottle with the label uppermost so that poured solution cannot stain and obscure the label. We want to confirm the solution with the surgical team member before pouring. So we basically want to hold it and show the surgical team what we are pouring into the basin before we pour it. Sterile basins into which sterile liquids will be poured. They're generally placed at the end of the table to avoid splashing over the entire sterile field. And with as little of the bottle as possible over the field, you hold it at a height of about 1 to 2 inches over the bowl, and then pour the solution gently so that no splashing occurs. Why not splashing? Splashing of liquids can destroy a sterile field by allowing the microorganisms to move from the unsterile tabletop through the wet drape that forms the bottom of the sterile field. So we want to be very careful not to splash. So surgical scrubbing. The surgical scrub consists of scrubbing with an antimicrobial agent. Surgical scrubbing involves two basic methods. You have a numbered stroke method and you have a timed method. So let's look at the pictures as we read the caption. So drying the hands and arms after a surgical scrub. So after you're all scrubbed, you would pick up the sterile towel from the table, being careful not to drip water on the gown beneath it. You want to fold the towel lengthwise. In C, you're going to use one end of the towel only to dry one hand. You're going to then rotate the arm as you proceed to dry it, working from the wrist to the elbow. Do not allow the towel to contact the scrub suit. And then after the arm is dry, bring the dry hand to the opposite end of the towel and begin drying the other hand. And you dry the arm using the blotting, rotating motion. You proceed to the elbow again, and then the towel must be discarded in the linen hamper or kick bucket. So in addition to the actual scrubbing of the hands, there's a proper way then for also drying the hands as well. So let's talk about the scrubbing of the hands themselves. So we remove jewelry and watches. We clean the subungual areas with a nail file. So underneath the nails, lots of dirt and bacteria can be under that. We scrub the sides of each finger, between the fingers, and the back and front of the hand for 3 minutes. Scrub the arm with the hands higher than the elbows. So that's important. Hands higher than elbows. Each side of the arm is washed to 3 inches above the elbow for 1 minute. You repeat the drying process, repeat the process for the other hand and arm, and then the hands remain above the elbows at all times. And then we just talked about the drying method then. So putting on a sterile gown. So now you've scrubbed, you've dried your hands. Now we got to put on that sterile glove or sterile gown. So in A, you're going to grasp the gown firmly and bring it away from the table. It's been folded so that the outside faces away. In B, you're going to hold the gown at the shoulders, allow it to unfold gently. Do not shake the gown. In C, you place hands inside the armholes and then guide each arm through the sleeves by raising and spreading the arms. Do not allow the hands to slide outside of the cuff of the gown. So notice her hands are not outside of the cuff of the gown. And then the circulator nurse or assistant assists by pulling the gown over the shoulders. And then there's a tab that would be given to the nurse to hold. The person that's gowning turns around, can grab the tie, and then the gown is tied. So gowns and gloves are put on after the surgical scrub. Gowning can be done in two ways. There is either self-gowning and then gowning another person. And after the gown is on, only the sleeves and the front of the gown down to the waist are considered sterile. So that's an important fact to remember. So only the sleeves and the front of the gown down to the waist are considered sterile. Everything below the waist is considered unsterile. And to maintain sterile technique, once in the sterile gown and gloves, the person must pass each other back to back. That's another important fact. To maintain sterile technique, once in a sterile gown and gloves, persons must pass each other back to back. All right, let's talk about putting on sterile gloves then. So this is the self-gloving open technique. All right, so pick up the glove by the inside cuff with one hand. Notice the cuff is folded over. Do not touch the glove wrapper with the bare hand. In B, you then slide the glove onto the opposite hand, leaving the cuff down. In C, use the partially gloved hand, slide the fingers into the outer side of the opposite glove cuff. In D, you slide the hand into the glove and then unroll the cuff. And then in E, with the gloved hand, slide the fingers under the outer edge of the opposite cuff and unroll it gently using the same technique. So in this way, then, the outside of the glove has never touched the skin, never touched the hand. And then gloving over a sterile gown. So this would be where we just saw that they did not put their hands all the way through the cuffs. This is generally done in a surgical setting. So self-gloving close technique. Lay the glove palm down over the cuff of the gown. The fingers of the glove face toward you. We're in B and C, working through the gown sleeve, you grasp the cuff of the glove and bring it over the open cuff of the sleeve. And then in D, then you can see unroll the glove cuff so that it covers the sleeve cuff. Proceed with the opposite hand using the same technique. Never allow the bare hand to contact the gown cuff edge or outside of the glove. All right, so there's both ways I've seen it done. I mean, when I was in cardiac cath, I used the method that we just talked about, the open technique, but I had a nurse that worked with me. She always used the closed technique. Okay, so it just depends on preference unless specified by the surgeon or the doctor that you're working with. These are the other steps that we had just listed there. Once again, you can see D and E there. Unroll the glove cuff so that it covers the sleeve cuff. F through I, proceed with the opposite hand using the same technique, never allowing the bare hand to contact the gown cuff edge or outside of the glove. So truly, for all of this that we've been talking about, really the only time that you as a tech would do this is if you're going to be doing a procedure such as a myelogram or an arthrogram, Those would probably be the main ones that you would be actually doing this, not necessarily putting the gown on. But certainly if you go into special procedures at all, interventional radiology, cardiac cath, or surgical tech, you may have to perform these different maneuvers as well. All right, so here is showing you gowning another person. So this generally is done, like I said, in surgery or in special procedures, cardiac cath. The person in green there would be the doctor, and then in blue then would be the patient. I'm sorry, the person that would be assisting the doctor to put on the gown. So you would grasp the gown. So this is A, grasp the gown so that the outside faces toward you. You would hold the gown at the shoulders, cuff your hands under the gown's shoulders. In B, the person steps forward, places his or her arms in the sleeves, slide the gown up to the mid-upper arms, and then C, the circulator assists in pulling the gown up and tying it, and then gently pull the cuffs back over the person's hands. Be careful that your gloved hands do not touch his or her bare hands. So in A and B, you can see that person in blue has already scrubbed in. They've got the sterile gown on, sterile gloves. They've grabbed the gown off of the table. Now they're going to assist the doctor in putting their arms through the sleeves. And then you have another, in C, another person, a circulator, then is going to then take and clasp the gown up at the neck area. There's also going to be a tie on there, and the doctor would hand that to the circulator. There's like a little piece of paper attached to it, and then the doctor would turn around, the circulator would pull off the paper, and then the doctor then could tie the gown because then the ties would still remain sterile. Okay, and then you see in D, once again, the sterile individual is just helping then the doctor. Two-person gloving, so gloving another person. Once again, you can see there's a person who is already sterile in a sterile gown, sterile gloves. They're going to now help. This could be the doctor, for example, putting his or her hand into the glove. So in A, you're going to pick up the right glove and place the palm away from you. Slide the fingers under the glove cuff and spread them so that a wide opening is created. So you're going to open up the glove. You're going to allow then the doctor to push his or her hand then right into the glove. And then keep thumbs under the cuff so that you can stabilize it while he or she pushes the hand into the glove. The person thrusts his or her hand into the glove. Do not release the glove yet. C, gently release the cuff. Do not let the cuff snap sharply while unrolling it over the wrist, and proceed with the left glove using then the same technique. So now you're done and you want to remove the sterile glove. So you grasp the edge of the glove, unroll the glove over the hand, discard the glove. It's not shown in the pictures. And then in C, with the bare hand, grasp the opposite glove cuff on its inside surface, and then D, remove the glove by inverting it over the hand and discard the glove. So in this way, you're not allowing then your unprotected hand to touch the outside of the glove, which could have been contaminated with blood or other fluids. Let's talk about dressing changes. So dressings are best changed in a team setting with another healthcare professional. The physician is responsible for ordering dressing changes and reapplication. You secure consent before beginning the procedure. All dressings are treated as though they are infected. Do not touch a dressing with bare hands. You never know what type of pathogen may be on that dressing. The hands are washed and patient privacy and consent are obtained. The adhesive tape surrounding the dressing is removed. The dressing is removed with forceps or gloved hands, wrapped and then placed in a plastic bag. And then for reapplication, sterile technique then is followed. Let's talk about someone with a tracheostomy. So, first of all, what is a tracheostomy? It's an operation performed under sterile technique that involves incising or opening the skin over the trachea and then making a surgical incision into the trachea. What does it do? It provides an airway during upper airway obstructions. It's an emergency procedure only, and communication with tracheostomy patients is critical as their anxiety level is typically high. Generally, as radiographers, we're not really involved in this process. This would really be more for like an emergency room setting, because as it says here, it's an emergency situation. But you might witness it if you're waiting to do a portable. But generally speaking, we don't really get involved with that. That's more for the nurse in the emergency room to do this. Now, we might care, though, for the patient with a tracheostomy, like if we go to do a portable, for example. So the technologist caring for the tracheostomy patient must also be sensitive to unmet and inexpressible needs and the need to keep the patient anxiety level low. To minimize the possibility of infection, the technologist should not touch the tracheostomy area except under conditions of sterile technique. And it is recommended that only properly trained personnel suction the tracheostomy patient. So this is not within our scope of practice. Chest tubes. You are going to encounter patients that have chest tubes. They're also known as thoracostomy tubes. What do? They drain the intrapleural space in the mediastinum of any fluid or air. They do this by creating negative pressure, and it's done in several scenarios. If there's atelectasis, which is a collapsed lung, if there's a pneumothorax, which is air in the pleural cavity that can lead to atelectasis, and then hemothorax, blood in the pleural cavity. Could also be done to remove pleural effusion, which is a buildup of excess fluid between the lungs and the chest cavity. It can be used if the patient has empyema or pus in the pleural cavity, and generally patients that have had open heart surgery will generally have a chest tube in. Common insertion sites for thoracostomy vary with the intrapleural substances that are being removed. Usually inserted into the 5th to the 6th intercostal space. They're inserted laterally and at the mid-axillary line. And they can be as high as the 4th intercostal space and as low as the 8th. Radiographers, our role we often perform chest radiography, especially portable procedures, before and after the insertion of chest tubes to ensure proper placement. So that generally is our role. We're not really involved in the insertion of the tube, but we are going to have that patient in our care, especially when we're doing a portable. So this is the way that the chest tube setup looks. Images are performed to confirm chest tube position and chest status. You got to be really careful because these hang off of the bed, the tubing does. You want to be careful not to catch the tubing on any of your x-ray equipment that you're using, especially during portables. And the exterior assembly of the chest tube, very, very important, must always remain lower than the patient's chest. So that box, it contains fluid water, and basically what this does is then if there's any intrapleural air, the tube will remove the air. That air will bubble up through the water, and then the air then cannot get back in to the patient because obviously air cannot go back through the water. Let's talk about urinary catheters. So there's two different types. You've got straight catheters, and then you've got Foley catheters. And these are called indwelling catheters, and the Foley catheter you can see has actually a balloon. So once it's inserted through the urethra and then into the bladder, this balloon is blown up so that then the patient cannot push the urinary catheter out. Right. So what do we do, or what are they for? Okay. So obviously emptying the bladder, right? It's a tube that's placed into the bladder. It's going to be done to relieve bladder retention. You can use it to irrigate the bladder. So if they need to flush out the bladder, it can be done to introduce drugs into the bladder, to permit accurate measurement of urine output. So that's a big one because there's markings on the bag that would indicate how much urine is coming out. To relieve incontinence. Incontinence, remember, is the patient cannot control their urine, the flow of it. And then if the radiographer empties the urine collection bag, then output must be measured and recorded unless otherwise noted. Once again, this is generally not a technologist or radiographer role. Usually the patient will come down and then we'll do the x-rays and then we'll send them right back up, where then the nurse then would be in charge of emptying the urine collection bag. And it's important because you need to make sure, sometimes they're doing input-output studies where they're measuring how much fluid is being input into the patient and how much is then being excreted by the patient, and those numbers can be very important from a physiologic standpoint. So as far as the placement, once again, this is not within our scope of practice to put in a urinary catheter, but we do deal with patients that have them. So this is kind of how it works here. You can see the body in cross section. The tip of the catheter is in the urinary bladder cavity. Once that catheter is placed into the bladder, that little balloon is blown up if you have a Foley catheter, and then the tubing is taped to the patient's thigh, and then the end of the tube is attached to a calibrated drainage bag. So you can see, as I mentioned, there's measurements on the bag, and those measurements are going to be important, once again, determining how much urine output the patient is having. And this is very, very important. Just like the chest tubes, the container for the chest tube has to be below the level of the chest. These drainage bags must be kept lower than the patient's bladder at all times. And why? They work off of gravity. So you don't want to lift that bag higher than the level of the bladder because the bag itself is working by means of gravity. If you lift the bag up, the urine is going to flow back into the bladder, and once it gets into that bag, even though this is a sterile procedure, there could be bacteria in there, and then you would reintroduce it into the bladder. So it says drainage bag must be kept lower than patient's bladder at all times to prevent retrograde flow into the bladder, so that backward flow into the bladder. All right, intravenous and intra-arterial lines. So sterile technique is required for the insertion of lines or catheters into veins and arteries. And once again, we as radiographers are not responsible. It's not within our scope of practice to insert these lines into the patient, but we do deal with patients that have them, so we need to understand what they are and what they're used for. So intravenous lines are used for a variety of purposes, including the introduction of medications and intravenous fluid and measurements of central venous pressure, CVP. There's also a special catheter, the Swan-Ganz catheter. It's a special type of intravenous catheter. It's used to measure the pumping ability of the heart. So the tip of the Swan-Ganz is actually in the chambers of the heart, and it can be used to measure the pressure or pumping ability of the heart. And then we have arterial lines. These include the radial arterial and femoral arterial lines. So one in the arm, one in the groin area. These lines are used for drawing blood and measuring blood pressure. And then they require imaging, once again, to confirm placement and functionality. So our role would be to take x-rays to confirm the placement. There's a radiopaque marker at the tip of these tubes so that the radiologist can determine where the tip is to alert the attending physician that it's in the right place or the wrong place. Technologists must be ever aware of lines and their equipment and positioning. So once again, you're going to be dealing with a lot of patients have a lot of tubes, especially when you go to the ICU or the CCU. These patients they're just loaded with tubes, and we've got to be very careful that we don't dislodge them as we're positioning our patient for X-rays. Some patients have pacemakers. Permanent pacemakers are electromechanical devices that are inserted under the patient's skin to regulate the heart rate. Pacemaker units are approximately 1 inch in width, in diameter, and in thickness. They weigh just a little over 1 ounce. The role of the radiographer is to operate the fluoroscopy unit, which will allow the physician to place the guide wire and the pacemaker assembly correctly. So this would be something where we would be involved using the C-arm while the doctor is placing the tip of the catheter, the lead of the catheter into the heart. We're going to use fluoro to help them in making or getting the right path into the heart. Newer pacemaker designs are MRI compatible, but they'll still ask about this in a patient's going to have an MRI procedure if they have a pacemaker or not. Portable and surgical radiography pay strict attention to sterile technique. Okay, so this would be especially important in the surgical suite. Be aware of the sterile corridor that we talked about and respect its dimensions. Portable fluoroscopy requires the image receptor and the patient be draped. The newer DR detectors, they're gaining popularity in surgery. The surgical draping of the C-arm and the patient is performed by the surgical team, and C-arm draping may use any of these designs. Neonatal portable radiography, this is done for very high-risk infants. Extra care is required with aseptic techniques, often performed for transient tachypnea of the newborn. So that's TTN. Transient means comes and goes, tachypnea, rapid breathing, or respiratory distress syndrome, which is RDS. The task of obtaining images of the infant and maintaining a safe environment without cross-infection is very important. And even though we don't generally shield now in radiography anymore, gonadal shielding is still important with these neonates. Their cells are rapidly multiplying, and we know from the law of Bergeret and Tribunal that the more rapidly that cells are going to multiply, the more radiosensitive they are. So you could use a shadow shield where the shield is pulled into the shadow of the collimator light and projected onto the patient, so you can see where the shielding would be, or a contact shield, a small piece of lead could be used over the gonadal region. All right, taking radiographs in the operating room. So you have to make sure that you're in scrubs, right? Dressed appropriately. You're being aware of all the sterile areas. You identify the surgical team and the float nurse. You take charge of your area of responsibility, which will basically be using the C-arm or a portable unit perhaps. Position the image receptor and the X-ray unit appropriately and communicate clearly with operating room staff. So generally, once you're all positioned and you're going to take the radiograph in surgery, you want to alert everyone that you're going to be taking that radiograph. So you might yell out X-ray so everyone knows. For portable radiography, minimize patient movement if possible. All precautions for the safety of the patient and healthcare worker have to be considered. You want to use proper protection protocols, and you want to follow recommended good practices for removal of any hazardous waste. And in conclusion, then, the purpose of aseptic technique, what is it? It's to reduce the number of harmful microorganisms. Surgical and medical asepsis are required for a variety of clinical situations. And sterile techniques require proper gowning, gloving, and masking practices. The technologist will often perform in a surgical environment, and they have to be aware of proper surgical techniques and medical imaging of patient tubes, lines, pacemakers, and catheters. That requires special aseptic techniques and imaging considerations. These are some YouTube videos that you might want to watch to help you with what we talked about today. So hopefully this helped you in understanding what we mean by aseptic techniques. Once again, unless you're going really into IR or you're going to be a surgical tech in the operating room, or if you're going into cardiac cath, you're really not going to have to be putting on surgical gowns and gloves, maybe certain sterile gloves, because like I said, if you're doing a myelogram, you have to open the tray, put things onto the tray. But generally speaking, these practices of putting on gowns and sterile gloves are more for the IR tech. But certainly the other things we talked about, you got to be really careful when you're doing portable radiography. You want to make sure that none of these tubes gets hooked to the machine, and as you're pulling the machine away, you don't want to pull out any tubes or anything. You want to also be careful in portable radiography when we're lifting patients, right? They're going to have tracheostomy tubes, and they're going to have different IVs and different intraarterial lines, things like that. So we've got to be very gentle with them. And at any time, when you're doing a portable and you don't think you can handle it yourself, please ask the nurse for assistance. They'll definitely help you. I hope that you guys found this interesting today. And if you have any questions, as always, you can just let me know, and I will try to answer them to the best of my knowledge.